We are now going to move to our next session, which is going to be our Wingchair discussion. It's advances in treatment. All right, let us call up our panel. First of all, I would like to introduce you, and I'm going to have him introduce the panel. Dr. Anil Kapoor is a medical Uro-Oncologist, at McMaster University at the healthcare there. He's also the chair of the Kidney Cancer Canada Medical Advisory Board. And that is a tremendous organization. And I'll tell you why, because they offer everything you see on our website and everything that we publish gets run through guys like this who actually know what they're talking about, unlike me who just makes it up as I go along. So please welcome Anil, and Anil will introduce the rest of the panel to you.
Super. Thank you. First I want to introduce our faculty. We have some great faculty, two medical oncologists, one radiation oncologist, and two surgeons, myself and Dr. Feifer. So first we'll get Dr. Feifer up here. Dr. Feifer is a urological oncologist at Peel Cancer Center associated with Credit Valley out in Oakville. Come on in. And he's done a great amount of work with kidney cancer and prostate cancer patients as sort of the preeminent uro-oncologist in the Oakville corridor. So welcome for coming. Thank you for coming. And now we're going to have also Dr. Anand Swaminath. Dr. Anand Swaminath is a radiation oncologist who is at the Juravinski Cancer Center, and he's done a lot of great work nationally and internationally in radiation therapy for kidney cancer. So that's going to be a... Thank you for coming. One of the paradigms that we've talked about over the years is that kidney cancer doesn't respond to radiation, and that's really been told by a lot of oncologists, which is incorrect now. We have new data we'll talk about during the next hour about how kidney cancer does respond to radiation for their mass as well as for metastases as well as for other areas. And I think it's a very exciting area, and we can talk about some patients that have done very well from radiation and how that's impacted. To me, that's probably the most exciting part of it all, and looking forward to your input on that. So then we have Dr. Henry Conter. Dr. Henry Conter is dressed in a beautiful white sweater here today, so come on up. So, but there's more to him than that. Dr. Conter comes to us as the head of oncology at Brampton Cancer Center, and a very prolific and well-researched medical oncologist. Thank you for coming. And then we have Dr. Aaron Hansen. And Dr. Aaron Hansen, for those... Aaron, are you here? There he is. Excellent. He's behind the pillar. Dr. Hansen is the new medical oncologist at Princess Margaret Hospital. So all you have to do is say Princess Margaret and everybody swoons. But welcome to Princess Margaret. She takes over the big shoes of Dr. Jennifer Knox, who, as you know, has gone on to other disease sites. So big shoes to fill, but he's well published and well rehearsed in GU oncology. So we look forward to that key guy at Princess Margaret. So thank you for coming. So this is our panel, and we're going to make it interactive to make sure that everybody, I think part of the new way we're going to do it this year is have some interaction, talk about perspectives in kidney cancer and how far we've come over the last decade or so, which has been amazing, but also talk about paradigms such as active surveillance. A lot of people, once they're diagnosed with cancer, they sort of say, well, you've got to take it out. And that's not always the case. And we'll talk a little bit about active surveillance and just keeping an eye on small masses. So we're going to talk about localized disease as well as metastatic disease and new horizons that are coming up in the next year for treatment of kidney cancer, specifically immuno-oncology drugs, and a lot of questions about that and how that fits in. And also future paradigms of that. So just as a template of where we're going, I'm going to use this clicker here. Part of it's just some knowledge about, as we start off the day, about what kidney cancer staging is. So first stage cancer is when it's just in it's a small mass, so it's less than 7 centimeters. T2, or second stage, is when it's over 7 centimeters. Stage 3 is when it's into the veins. And stage 4 is when it's spread beyond the cancer. In general, kidney cancer is relatively slow growing overall. So it takes some time for these masses to grow over time and spread. And so we see patients who have large masses, and they've probably been there for many years. And it's hard to know because the only real sign is blood in the urine or some pain. And often it's at more of an advanced stage at that time. This cystoscopy that we talked about, I would reassure you that most patients with kidney cancer don't need a cystoscopy. Cystoscopy is indicated when you have blood in the urine, and often that's a lot of kidney cancers that we find don't have any blood in the urine. And it's not as bad as you said. When we do it our way, it's much easier. I think for him, we use this one, but for the regular patients, it's a really small, thin one the size of a piece of spaghetti. It takes about 5 minutes, and it absolutely doesn't hurt. And none of the patients complain except for him. So just so you know, I just thought many times I probably will. So this is what we're going to talk about in terms of the paradigm of how we're talking about active surveillance, surgical management for localized disease, and medical management for advanced disease. So I'll just start off with that as a discussion point. Active surveillance, I've talked a little bit about that. Dr. Feifer, what are your comments about active surveillance, and when is that indicated for patients?
Is this okay? It's working. Thank you. So active surveillance for kidney cancer is underutilized, I find, especially in the septuagenarians and octogenarians. When we balance quality of life and survivorship with other competing risks and so on, there's plenty of evidence in the literature from very, very wonderful institutions in North America that suggests that it's very safe to watch particularly small renal masses, biopsy-proven renal cell carcinoma in patients who have other significant medical risks, such that intervening for their kidney cancer, although altruistic, might not be the best choice for them. And careful watching and careful surveillance of these masses is often a very good and underutilized strategy. It's not for everybody, though. There's no question that if you're doing surveillance, you have to survey the patient. You can't just set it and forget it, as they say. It's something that has to be done effectively and within a defined program, so it can be done safely in case something happens and you have a bad actor. You can intervene in a timely fashion.
Yeah, so I would agree with that. Is that basically if a patient comes in with a 2-centimeter mass in their kidney they found out by accident on an ultrasound, you can biopsy that, and the question of a biopsy is also debatable, but there's more move to biopsy these small masses to see what they are, because 25% of them are not cancer. So if you have a 2-centimeter mass and it's not a cancer, you can just you don't have to have it removed with surgery. And if you biopsy it and it is a tumor, it is a cancer, often these masses may not grow very quickly at all. You could just watch it in perpetuity, and if it never changes, you never need surgery, and it's not biologically active, just sitting there quietly. And that's the controversy of active surveillance. If you have somebody who's 80 years old, you could just keep an eye on that with an ultrasound or a CAT scan maybe, or an MRI every 6 months to a year, and the radiation risk is minimal. But if somebody who's 40, that's where there's more of a controversy about active surveillance, and there's some groups, specifically Princess Margaret with our colleagues at Tony Finelli and Michael Jewett, who advocate that it's okay for 40-year-olds to have active surveillance. But there's some controversy there. I actually don't agree with that. I think that if somebody is 40 years old, rather than have an MRI every year with anxiety for the next 40 years, I think the surgical risk is less now with the laparoscopic and robotic techniques, that it's better to have that removed at 40 years of age than have an MRI every year for the next 40 years until they're 80. But that's controversial, and if Dr. Finelli was here, he would say, no, you can watch it, but I don't agree. So,
I have to echo Anil's words. I agree with him wholeheartedly. I think there are risks with long-term radiation if you're having multiple CT scans a year. It is a risk that is still under investigation. I think that when I survey patients with kidney cancer, it's very rarely a CT, most of the time ultrasound, which has no radiation risk. And if there's something that is growing or something that is different, then we can institute an MRI or a CT or something at that point, a sort of a targeted approach. But there's no question that radiation, annual CTs or biannual CTs in a 40-year-old patient with a slowly growing renal mass that is surgically curable, And with minimal morbidity, with advanced surgical techniques and good surveillance, I think there's a role for surgery in those patients, and that is reflected in a lot of the Canadian guidelines now.
What I'm asking is a lot of people go about the risks of CTs, but how would that materialise? What is the risk? What would happen?
So some of those risks, first of all, there's two types of risk. We talk about psychologic risks and physical or physiologic risks. There's a lot of anxiety and a lot of nervousness and so on. We've had a wonderful keynote address about addressing those fears. There's a lot, that's a real thing. So I have patients who come in scared out of their mind to get their CT result. And I try to speak to that quickly and try to lessen anxiety. But the physical risks, things like secondary malignancy, and fibrosis and things of these things are very rare, very rare. But if you're that very rare individual who gets a secondary malignancy after 100 CTs, having had your kidney cancer surveyed for 25 years, I mean that's a real thing. So there are a lot of investigators that are trying to actually calculate what that risk is, particularly the secondary malignancy risk. And for different CTs, it's a very hard thing. It's a moving target because not all CT scans are equal. There's low-dose CTs, high-dose CTs. How many times you go through the scanner per imaging and per frequency? It's a difficult thing to pin down. But it's really secondary malignancy that we're talking about.
Yeah, just speaking from a radiation oncology perspective, I mean, so the risks are very minimal, even with radiation therapy. If you have high-dose radiation, the risks are very minimal with respect to second malignancy down the road. So, but it's always important to counsel folks about that risk, right? So it's not negligible to the point where you shouldn't explain it, but I tend to always, particularly in younger patients, explain those risks fairly succinctly to them so that they understand. But I think that sometimes the benefit, as they were saying, outweighs the risk. The benefit of having the CT scan maybe outweighs the risk of it, 20, 30 years down the road. The second part of it is, even if a secondary malignancy or a malignancy in general happens 20 or 30 years down the road, it may be difficult to pinpoint whether or not that malignancy was related to the fact that the person had CT scans for that length of time. So the sort of cause-effect relationship, I think, is something that still is undergoing sort of active investigation. We really don't know the answer to that question quite as yet.
Does that also depend on what stage you are? I mean, I'm stage 4, so obviously the risk 25 years down the road, well, here's hoping, but does it depend on what stage you're at?
I think it depends more so on what the sort of plan is for treatment. So I think in someone with stage 4 disease, there's probably more active treatments that are happening at that time. So the risk of the CT scan is much less than, I wouldn't even really discuss that in the context of someone with more advanced disease, because you want to survey how they're doing with their treatments with the CT scan. So we really don't discuss those risks in general.
Good. Just to move on then, those are great. That's some great dialogue. So just for localized disease, I think one of the big messages is partial nephrectomy is opposed to total nephrectomy, and I'll talk a little bit about that. But this is the advances we've had in the last while, is basically minimally invasive surgery, doing these surgeries laparoscopically or robotically with keyhole surgery, partial nephrectomy, and scarlet surgery now, as well as probe ablation. And probe ablation is where you can burn the tumor off or freeze the tumor or microwave the tumor. So all sorts of things you can do to these tumors when they're small. And this is how the paradigm has changed. In the old days, we would do a big open incision through a flank incision, take out a piece of rib, and now we're able to do these laparoscopically through keyhole surgery, so your recovery is better. And the key message is that the operation is exactly the same or even better laparoscopically than with open surgery. Many patients say, well, why don't you just make a big incision and take it out to make sure you got everything? It's the studies have shown, multiple studies, that you do it laparoscopically, your cure rate is exactly the same, if not better, than with open surgery. And so that's a good message to take home. And so now we're also doing these partial nephrectomies laparoscopically and robotically, where you can remove the tumor. In this picture, the bottom half is a small tumor, and you can excise this laparoscopically off the normal kidney and leave that normal kidney for later on in life, where if you developed medical issues such as diabetes or hypertension and so on, it's good to have 1.5 kidneys or 1 3/4 kidneys rather than just one kidney, so you can stave off any issue of dialysis or cardiac morbidity. So we're doing these now partial nephrectomy, and if you're not offered a partial nephrectomy by your urologist, you should get a second opinion by another urologist just to make sure that you're covering all the bases. Sometimes it's not possible. If the tumor is in the middle of the kidney, then we can't do a partial nephrectomy, but it's always good to get that other opinion about it, because if it's possible, then it should be done. And this is what it looks like after you excise the tumor. You see most of that kidney is still there, and then you put the tumor into a little baggie and take it out. Now we're doing these robotically as well, which helps us have more range of motion to these surgeries. Not a huge difference in laparoscopic, but more range of motion to suture and better outcomes in terms of bleeding and securing the defect after the surgery. Then we have scarless surgery now, where we can do this just with through the belly button, and this is actually pioneered in London. I'm not sure if Nick Power is here yet. Nick, are you here yet, or? He's the next speaker, but he should be here shortly. He's probably still sleeping. In London, actually, they've done a lot of scarless surgery or single port surgery, where they are able to remove these tumors with no incisions at all, even the laparoscopic ones, just all through the belly button. And we use these bendy instruments to do the surgeries. And now they have a single site robot. We hook up this robot at the belly button, and with these little octopus kind of device, you have no scars whatsoever, and it's all through the belly button. So technology is really moving along quickly for surgical management of these kidney cancers with excellent outcomes, and this is what it looks like at the end. So you can get back in your Speedos on the beach. Then we have, any comments on that? You want to make any comments on surgery right now? Okay. Exciting stuff, absolutely. So now we're also doing burning of these tumors called RFA. This is where we use these umbrella type of probes where you can see the probes come out like an umbrella and burn the tumor off. And this is no incision whatsoever. The radiologist does this in most centers, and they put a probe through the skin into the tumor if it's less than 3 centimeters, and they just heat it up and kill all the cells inside of it. And that's really exciting technology, and the literature worldwide is suggesting that the cure rate from these kind of probe ablations is as good as with surgery. It's never going to be quite the same as surgery, I think, because the tumor is still there, but all the cells are killed, but it's still there, just all necrotic tissue. Whereas with surgery, the tumor is gone completely, so there's much less chance of the cancer coming back. And this is what the probes look like, and then you just retract it and pull it out, and you go home within about an hour or so. And now we're also freezing them as well. We put this probe inside there, and you make a little bit of an ice ball, and that's done in the CT scanner where you can burn where the red arrow is, and you burn the tumor off that way. And this is also happening more so in the States than in Canada. In Canada, we do a lot more probe ablation because the results are pretty similar to cryoablation. And then we have radiation, and I'm going to defer this to Anand. This is your moment to shine. You got five minutes.
5 minutes. Terrific. I just want to turn back the clock. So about 10 years ago, or maybe even 10 to 15 years ago, now it's 2016, right? So 10 to 15 years ago, radiation was not even in the picture when it came to kidney cancer. Part of the reason is that we were only able, as radiation oncologists, to give patients a little bit of radiation every day over about 5 to 6 weeks with the purpose of trying to shrink the cancer down. And there was a lot of studies that have been done sort of in the past 10 years that have indicated that particularly in kidney cancer, that doesn't work. You need to increase the amount of radiation you give per day. And only then will kidney cancers actually start responding to that treatment. And so as radiation oncologists, we had to find a way to better deliver radiation effectively. And because we're increasing the amount of dosage, do it in a very focused way. So this whole technique called SBRT, there's different ways of calling it. So this is called stereotactic body radiation therapy. It also is referred to as stereotactic ablative radiation therapy or stereotactic radiosurgery. It's all the same sort of technique, but basically it's similar to what RFA does, but with radiation, and it's completely non-invasive in that a radiation beam or beams focus on the tumor and create a very, very high dose around the tumor, and then what it does is it actually drops the dose very quickly beyond that tumor. So what you get is minimal sort of side effect damage to the nearby organs, which in the case of the kidneys include the liver, the bowel, and sometimes the liver, the large bowel, and the small bowel. And so we've done this a lot in different cancers. So SBRT was sort of pioneered in lung cancer. And so I treat a lot of lung cancer as well. And so what we noticed was we were controlling cancers really, really well with this treatment. And we were doing it in patients who couldn't have surgery. initially because of various reasons. Either technically they weren't operable, or they were sometimes too big for things like RFA or cryoablation, or patients couldn't go for an operation because they couldn't actually get through an operation because of other medical conditions such as cardiac disease or lung disease or what have you. So we were offering radiation to these patients and we were seeing excellent results. And in lung cancer, almost as good as surgery. And so now there's studies in lung cancer where we're trying to compare SBRT to surgery. We're not quite there yet in kidney cancer. But I would say this, if you have a patient with a large tumor that's inaccessible for RFA or that is not operable either by a nephrectomy or partial nephrectomy, then I think that SBRT may be an option for this patient. It shouldn't preclude surgery as the standard of care. I think surgery is still the standard of care for patients with localized renal cell carcinomas or other types of kidney cancer. But in certain scenarios where the tumor is larger or it's growing fast or it's in a scenario where a patient can't have an operation, this technique, SBRT, is becoming more and more in the forefront. And we actually have a study open now in Hamilton and in Sunnybrook, and we're rolling it out to other centers across the country where we're utilizing this technique. And part of it is we want to show that the technique is effective, because we think it is if we increase the amount of radiation we give per day. And typically all you need is 5 treatments or less to treat these tumors. And it's done as an outpatient. It's completely non-invasive. Most patients tolerate these treatments without too much difficulty whatsoever, apart from maybe some GI upset and some mild fatigue. But the one thing that we want to also show is that there's good quality of life after this treatment. The patients do well. They don't have lingering issues. And so part of the study that we're doing is looking at that quality of life aspect of it as well. The third thing, and the most important thing, I think, and the one sort of gray area in terms of what radiation does, is we're not sure how it affects the kidney particularly well. There's been not very good literature in radiation oncology community, and we've radiated kidneys for years. But you look at the literature, there's not very good literature data on how radiation actually affects kidney function. And I think that there's some investigators in Australia that are looking at this, but we're actually looking at this as well in Canada. And so we'll have a very good idea of A, if this is effective, which we think it will be, and B, what the effects are, both from a quality of life perspective, but also from a long-term damage perspective going forward. So I think it is an option, an emerging option for patients with localized renal cell carcinomas who can't have other therapies or are not ineligible for other therapies.
And a good segue into that is also the role of SBRT in metastatic disease. Basically, as we go into the more advanced disease in the next part of this, is that patients who have advanced disease, in general, we have these drugs that we're going to talk about with Henry and with Aaron. But sometimes if you have just a few areas of cancer that spread beyond the kidney, the best thing to do is to resect them and do surgery on them. So it's called metastatectomy. If you have somebody who has a kidney cancer that's spread to the lung, and there's a small lung nodule, you remove the kidney cancer and the lung nodule, that's the best chance for long-term cure. And in our center, we have, I remember one particular patient who has had 6 or 7 surgeries. We've taken out a piece of lung, another piece of lung, a piece of the liver, and a piece of their pancreas, and they're still alive and well 10 years down the road off of any drug therapy. So this role of metastatectomy is really, really the way to go if it's possible. And I think all of the panel would agree with that, is that surgical resection is really the best way to cure these patients, to cure patients like everybody in the room. The other thing about SBRT is that some patients have areas of cancer that are not accessible for surgery. So if somebody has 1 or 2 masses that are not accessible for surgery because it's too dangerous or not operable, that's where SBRT may be a good option, and it's emerging as a fantastic option. And I have a couple of patients already, both lawyers. I'm sure I'm not sure if they're here yet, because they're busy suing people somewhere. So both these lawyers have nodal metastases along their aorta. They've been on Sutent for a few years with growth and regression depending on dosage of the Sutent. And then we had Dr. Swaminath radiate those nodal areas, and they've been off of Sutent now for about 6 months to a year with promising results just for nodal disease. So this SBRT is a really promising option for metastatic disease that's amenable to it. So I think it's also a plug for the multidisciplinary team. It's just the medical oncologist or just the surgeon is not the way to go. Now it's getting the radiation oncologists involved at all these centers to get an opinion from the whole team about what's possible for optimizing an intent to cure. Any comments on that, Andrew? Or?
I want to echo that. I mean, I think every patient deserves to be seen by more than one provider and more than one discipline. And there's no question that when you present with advanced disease, it is there are plenty of disease paradigms that support an aggressive multidisciplinary management, and there's good things going on, and we're all talking up here and for the betterment of patients, and that's the way it has to be.
I agree. It's got to be patient focused, and I think that we still have so many tools in our arsenal now that we can use. It's about using them appropriately and using them in the right scenarios. So, SBRT may not be for everybody, and I think that's one of the things we have to get across. Or, certain drugs, treatments, surgery might not be for everybody. But I think as long as you understand that has been delved into as an option, then I think that that means that we are achieving patient-centered care.
We're going to go to questions in a second here, but so the message I think for everybody in the audience is that if you're not getting an opinion from if you're under the care of a medical oncologist, ask for an opinion from a radiation oncologist or a surgical oncologist to see if it's possible, and also vice versa. If you're under the care of a surgical oncologist and there's a question about other disease, make sure you get a medical oncology opinion and potentially a radiation oncology opinion. If it's happening at your center where they don't have them, get transferred or referred to another center that does have that option.
I just did SBRT. My last treatment was a few days ago.
You have to stand up or you get a cystoscopy.
I just did SBRT. And my last treatment was a few days ago. I'm here. I didn't think I was going to be able to be here. But everything that these doctors are saying about it is true. It was almost nothing. My question for the two of you is, I've been telling myself that I'm cancer-free now. And I know that there's not a smoking gun evidence to see, but what's the next step for somebody after SBRT in terms of figuring out what's what with the cancer?
I think that's a good question. I mean, whenever I counsel my patients about SBRT, particularly for metastatic disease, I think I'm shifting a little bit, sorry. But I always tell them that, the cancer in general is not curable. So the goal of the treatment is to try and control the disease. And there may be a time in the future that if we stop your drug treatment, which is what I generally do, I stop their drug treatment before I start SBRT because I'm worried about the interaction between the two therapies. And then once the drug treatment is stopped, then we kind of have a bit of a game we have to play. Like, do we restart the drug? Do we wait and see what happens in 3 months before we restart the drug? Because part of my worry is not necessarily that radiation won't control the disease, because we have very good results in terms of treatment of metastatic disease with radiation therapy nowadays, that we can control the cancer fairly well. My biggest worry, and I tell everybody this that I see, is I worry the cancer is going to show up somewhere else. And part of it is because the systemic treatment or the drug treatment they've had beforehand might be already doing that. And when you deliver a local treatment is not systemic treatment. I always say the radiation can control what it points at, but it's not going to point what it can't see. And so that's the one thing that we always have to kind of keep in our back pocket, that we follow folks along. And so, in your specific case, it would be following you along and seeing what the cancer does relative to how things look elsewhere. And if that means we keep you off your Sutent for longer, that's fantastic. But if that means we have to restart the Sutent in another time point, 6 months, 9 months, a year down the road, then we have to do that. But I think it's very difficult to know who's going to do what, who's going to be that person that goes a year, 2 years, 3 years without ever needing drug treatment again. And I always tell people, I don't have a crystal ball, I can't tell you, but I give most folks the benefit of the doubt. That being said, there are certain things that we can look at in terms of how we think people are going to do. So one thing is, how many spots are there to treat? The second is, how long has it been since your kidney cancer was first diagnosed to when that spot showed up? The third thing is, how well are you doing otherwise? Are you feeling well? Are you living your life normally? So there's different things that we look at when we're thinking about how well folks are going to do. And so that we take that all into account when we're following patients along after their treatment.
So I would support that. I think, definitely a multidisciplinary approach for these patients who fall under this umbrella of what we call oligometastatic disease can potentially have much better outcomes with really aggressive local therapy. And I think the paradigm for these patients needs to be on some level that you need to try and get as much bang for your buck out of every single treatment that you can. And oftentimes at our institution, we use SBRT to try and delay or at least not start drug therapy so soon. So if you can keep someone doing really well on SBRT or an aggressive local therapy before you need to start a drug therapy, then we would certainly advocate for that. And it's hard to pick out exactly who those patients are going to be. And as you heard, we don't all have a crystal ball, but certainly, we try these aggressive approaches in inappropriate patients.
Excellent. So, is there any questions before we move on to metastatic disease, for localized disease, surgeries, and that sort of thing?
So we're new to all of this. So I'm listening to everything, and I don't hear anybody talking about transplants. But does any of this treatment down the road, would that preclude the chances of a kidney transplant if that?
So I can answer that because I do kidney transplants. You can't have a transplant if you have active cancer. So and the reason why is not because we're trying to be mean, is that when you get a transplant, you go on immunosuppressive drugs. And these drugs suppress your immune system so you don't reject the transplant. And if you have any cancer cells in your body, it's like adding gasoline to fire. The cancer will just proliferate and grow like wildfire. So you have to be cancer-free for 2 years before you can be qualified for a transplant. They have to be off the treatments. So right now, as we'll talk about in a few minutes, these drugs that we're talking about, sunitinib and pazopanib and so on, these basically suppress the cancer in the body and make it go away, but often they may come back. So there are some patients that are cured from these drugs, but they have to be cancer-free off of drug for 2 years before they get a transplant. Does that answer your question? Yeah, good. All right, just to move on to metastatic disease, because Henry Conter is getting, he's saying, I got to say something. He's one of, it's like, I said, I wore this, I got this sweater, I wore it, I want to. He's going to be one of the Backstreet Boys soon. Sorry, is that being mean or?
You've just added to one of the 44,000 words that are going on every single day.
So the question I'm going to ask right now for your pad: who likes Dr. Conter's sweater? You don't have to worry anymore. So good. So just a few slides about the concept of how these drugs work. I know there's some new members in the audience who haven't been here before. So basically these cancer cells proliferate by inducing a blood supply. So we have a cancer cell. It needs to grow through nutrition in some way. So you have a blood vessel nearby it. And what's happened is this molecule called VEGF, or vascular endothelial growth factor. This VEGF molecule is secreted by the tumor cell and causes angiogenesis. And these blood vessels proliferate, and as they develop their own nutrition, they get more blood vessels and more prone to metastases. So it's called neoangiogenesis, and it promotes tumor growth. And this tumor cells get an octopus of blood vessels around it from this VEGF molecule. And as it gets more and more of this, it just gets bigger and bigger and grows faster. So you can imagine if you can knock out that molecule, that's maybe one way to help fight these cancer cells. There's other factors that are involved in this, and then we'll talk about the immuno-oncology thing. One of the things that one of the ways to fight these cancers is, again, through these inhibiting VEGF and other molecules that may cause these cancer cells to proliferate through blood vessel formation. But the other thing is that we're all exposed to cancer cells every day, and right now our immune system fights these cancer cells and kills them when you're exposed to cigarette smoke by somebody else, and they may promote carcinogenesis, and as a result of that, your T cells fight those cancer cells and kill them. But in some patients, these T cells are not working actively or overwhelmed by all the volume of cancer cells. And so that's where the immuno-oncology drugs work to supercharge the T cells. And we'll get you to talk more about that as we go through it. But that's basically the concept of these molecules. And so if you can inhibit the molecule itself or inhibit the receptor for the molecule, you can help diminish the blood vessel formation, and hopefully the tumor goes in remission and shrinks down. And that's basically how sunitinib and pazopanib work, and other TKI inhibitors work to shrink down these cancer cells. And these are the results you can see. You can see on the left-hand side you have a patient who had big liver metastases, and on the upper picture, these have shrunk down quite dramatically on these agents. So we do know that they work, and some amazing results from this. And this has all been a proliferation over the last 5 years. Before that, we were giving interferon. When I came from Cleveland Clinic many years ago, we were just giving interferon for patients with only about a 5 to 6% response rate, loss of toxicity. And it was a bleak time. And then over the last 5 years with these new TKI drugs, 5 to 6 years now, I think, we've seen some amazing results, and many of you in the audience can attest to that. And now we have the new exciting time of immuno-oncology to talk about that. So we have so many explosion of drugs in the last 10 years, 8 FDA or Health Canada approved agents, 3 classes of drugs, slowing of disease, and prolongation of life, which is really what we want to see. And this is the template that we have for immunotherapy. We have interleukin-2, interferon A, which we don't really use anymore, checkpoint inhibition, which is nivolumab, which we'll talk about throughout the day quite a bit, I'm sure. the VEGF inhibitors, which is shown in that cartoon, which are sunitinib, pazopanib, sorafenib, axitinib, and bevacizumab, which fights the VEGF molecule itself. Those first four, what they do is they hit the receptor so the molecule can't impact on it, whereas bevacizumab, what it does is actually bind to the VEGF so it can't go on. And then we have two new drugs that are coming up that you'll see more about, cabozantinib and lenvatinib, that are coming out, not approved or in Canada as yet, but also some great results just from a few months ago. And then we also have the class of drugs called the mTOR inhibitors, called temsirolimus and everolimus, and we'll talk a little bit more about that. And this is Henry's chance to shine. Henry, what do you have to say about these drugs?
Thank you for not making fun of my sweater anymore. First of all, I think it's important to kind of frame the conversation around the way in which a medical oncologist thinks about cancer, because these medications are certainly very exciting, but it's important to maintain the frame of what it is we're really dealing with. And the way I think about kidney cancer is the same way I think about a dandelion, in that it starts off in one place and it grows. And eventually it matures and develops seeds over top of it. And those seeds fly out into the body. Now, you can't see seeds just like you can't see dandelion seeds in real life once they plant it into the ground. What you see is when those dandelions grow from the ground, and in this case, that's what the new tumors are. They're essentially dandelions that have grown in different parts in the body. And so what these medications are really designed to do is very much the same thing that weed killer is designed to do, which is to try and keep things under control and hopefully kill some of the cancer. But none of these agents, or at least very few of these agents, have been able to reliably get rid of the cancer forever. And so although these medications are certainly very exciting, and when we look at how things were 10 years ago versus how things are today, we've seen huge improvements. On average, people live at least twice as long as they used to. We still, even with these new medications, are a long way away from finding a cure. In Canada, things are even more complicated because of our ability to access some of these medications. And I think the work that Kidney Cancer Canada has done, and the work that Deb specifically has done in bringing kidney cancer to the forefront, has really improved the lives of not only many of the patients that are here today. Some of us might not have been able to even get these medications without the work that's been done, but also moving forward in the future. I still rely very heavily on immunotherapy, and there are still patients, even though we've kind of moved on to newer and better things, I don't like the idea of throwing out the baby with the bathwater, and so even some of these old medications still have use. When you see or speak to your medical oncologist, you want to make sure that he's thinking about all possibilities. And so, for instance, although IL-2 is an extremely dangerous medication on this list, to date, it's still the only one that has been able to demonstrate in a very small minority of patients the potential opportunity for cure. Now, it's not covered in Canada, but you can imagine if you were or are a 30 to 40-year-old person who's otherwise completely healthy, even though it's expensive and even though it's potentially life-threatening, it's something that you still want to consider. I'm very excited about these new checkpoint inhibitors. So specifically, one that's approved and available on compassionate use is nivolumab, which is a medication that you get through the vein every other week. It has not been shown to produce cures, but is a very well-tolerated medicine, something that's better tolerated than almost any other medication that I've seen in the realm of kidney cancer, and has significantly improved the length of life that people have been alive for with kidney cancer, as well as their quality of life. And to me, when we're talking about a disease that we can't cure, length of life is very important, but quality of life is even more important. And so to have a medication that does both, to me, is a tremendous win. So I've been very, very excited. I don't want to take up all the time. We have an esteemed colleague as well, so I'll kind of leave it at that. But there's lots and lots to talk about when it comes to medical treatments in kidney cancer once it's spread.
That's fantastic, Henry. That's great. Do you have anything you want to add to that?
Yeah, so I mean, as Henry very eloquently put it, he summarized it very well. I think one caveat that I would attach to that is, with those older immunotherapies like the interleukin-2 and interferon, if you are going to receive those, you really want to get that from someone who's very experienced in doing that. So if you do have an oncologist that potentially doesn't have a lot of experience with that, I'd be very cautious about doing that. I think in the right hands, these treatments can be very, very effective. So that's the first point that I'd make. And the other point that I'd make is that, immunotherapies really are, there's a lot of buzz and there's a lot of hype around it, and there are some excellent results, and this is truly undeniable. But we don't want to forget about the other therapies that have been there with the TKI therapy, the mTOR therapies potentially that exist, that have been shown to have benefit, for a number of patients within this room.
So Aaron, along those lines, and so that's a great discussion. If somebody gets a first-line drug means it's a drug on a patient who's newly diagnosed, and then often these drugs have a limited efficacy unless you've had a complete response, usually about a year to 2 years or 3 years sometimes. And then you go on a second-line drug, which is the next line after the first drug has failed. How do you counsel a patient out of this menu of choices, sunitinib, pazopanib, temsirolimus, or IL-2, when you see a patient? And what's your discussion with the patient that comes in through your door?
Yeah, so unfortunately we're a little spoiled at the institution that I'm at, in that we generally tend to try to get all of our patients onto clinical trials. So this is my disclaimer. We would, if we had a first-line clinical trial, that is probably what they would go on to, and then we do have other second-line trials that they would go through. However, let us talk about this in the instance where we don't have any clinical trials to go through. So if the patient, if the patient has clear cell renal cell carcinoma, the two best first-line options that we have at this point in time is sunitinib and pazopanib. These are both approved. These are both reasonably equal in efficacy. There is some thought that pazopanib might have better quality of life, so less toxicity. We can debate the merits of the evidence that support that. But those are the two standard first-line options. The toxicities from both of these, to be honest, are rather tolerable. We generally can manage the toxicities that patients experience with both of these. So once they have progressed beyond this, these TKI therapies, this VEGF TKI therapy, the next step for second-line therapy would obviously, again, be a discussion around sequencing of the treatments that Anil showed you before. So there are mTOR inhibitors and there are other TKIs. So the question would be, do we do another TKI or do we do an mTOR inhibitor? Again, this is something that we've debated long and hard about what's the best sequence of therapies. Is it to do a TKI like this followed by another one like axitinib, or do we switch to an mTOR inhibitor like everolimus? And so I think that really comes down to what has happened with the patient in the first line, what sort of experience they've had, what sort of toxicities they've had, and then based on that you can then guide them into second-line therapy. I don't know what Henry would suggest.
We have a question here first. Why don't you go ahead?
Yes, the question, it's actually a little precision. The IL-2 treatment that you were talking about is accessible in Quebec through a special access program, and I believe there's a program like that that's emerging out west. So if anybody, obviously if you're here, normally it's the first treatment that's given, but you can contact Kidney Cancer Canada to see how that could unfold. The thing with that is that it's not in all provinces and that our health system is not totally friendly with intra-provincial exchanges because they're very costly treatments. But don't just forget about it. It can happen in very rare cases.
Just to clarify the role for IL-2, I think one of the things that we've seen is that the complete responses or regressions are seen with sunitinib and pazopanib, but it's about 2 to 3%. Whereas with IL-2, it's a fairly toxic drug, as Dr. Conter was saying, but the complete responses can be up to 8 to 9%. So it's still the drug that may have the most complete responses, but a fairly large toxicity, and sometimes patients have to be monitored in the ICU, and you have to be fairly robust to be able to tolerate this. Would you agree, Henry? Or?
Yeah. So certainly when it comes to IL-2, like I said, it is actually a very dangerous medication. Over 50% of patients will experience a life-threatening toxicity. So this is something that really should only be considered in very fit young patients with specific profiles around the way in which their tumor is behaving. And I think that that's something that's really important, especially with this group, because if 50% of you guys have been alive for over 5 years, you're doing so much better than the average. And many patients, or kidney cancer in general, behaves very, very differently in different people. Now, we've kind of talked about kidney cancer as only one disease, but there are many, many different subtypes of kidney cancer. So when we look at it under the microscope, they look differently, they behave differently, they respond differently to different treatments. And even amongst clear cell kidney cancer, which is for the most part what we're talking about when we're talking about these kinds of medications and kidney cancer in general, those kinds, even clear cell kidney cancer can behave very differently. So in some patients, you might not need any treatment right from the start. Some patients will have their cancers move very slowly. And I have a few patients that I've watched actually for over a year or 2 years without needing any treatment. On the other hand, I have some patients who not only have rapidly progressive disease, but their bodies also are trying to fight the cancer in using an immunologic mechanism. So what I mean by that is these patients will have fevers, they'll have rapid weight loss, they can have high calcium levels even though their cancer is not in the bones. And these are very different behaviors of this cancer which necessitate very different approaches and very different treatments. So I echo your comments. Not only do you, in Ontario, because most of us don't have a lot of experience with IL-2, if any experience giving IL-2, you still want someone who is familiar enough with the options for treatment, so that way you're having a full discussion, so that you can make a determination, is it worthwhile for me to make the trip to Buffalo or even downtown to PMH, which can sometimes seem just as far as Buffalo when you're driving in rush hour.
That's true.
So just to move on then, Aaron, do you want to give us a little overview for our audience about how the immuno-oncology drugs work?
Sure. So
I put this up here so you can remember it. So.
thanks. So basically the tenet of immunotherapy is that it's using your immune system to try and attack the tumor. And one of the drugs, nivolumab, which has recently been shown in a large phase 3 study to be effective, is a drug called nivolumab, which targets a PD-1, a PD-1 receptor. So PD-1 is programmed cell death protein 1, and essentially it has its partner, which is PD-L1, which is its ligand. It's like a lock and key mechanism. What this does is it allows the immune system to be turned off. So in normal cells, PD-1 actually has a function, which is your immune system doesn't want to be attacking normal tissue, so it uses PD-1 to signal to the immune system, hey, don't eat me. What the tumors do is that they co-opt that or they hijack that. And so they start to express these proteins, and then essentially the immune system is unable to recognize it and is unable to kill it. So what nivolumab does is it comes in this is very simplistic terms, but it blocks that interaction from happening, so it almost uncamouflages the tumor to your immune system and allows the immune system to then, the T cells to then respond and go in and attack and eradicate the tumor cells. So that's sort of the mechanism in a nutshell. And essentially how toxicities happen is basically autoimmunity. So it's the T cells not just attacking the tumor, but also attacking normal tissue. So that could be literally any tissue or any organ, skin, joints, colon, lung, everything. But to be honest with you, what we've seen with the single-agent immune checkpoint therapies is the toxicities are very tolerable, as Henry mentioned. These are incredibly tolerable drugs with very few toxicities. When we look at the data, fatigue generally tends to be the most severe toxicity that patients experience, and then skin toxicities such as rash and itch. But there are other things like that are more severe that we can go into in detail.
So I'm just going to put Henry on the spot because of the sweater. So Henry, which patient do you think is the best patient for nivolumab? And do you think that all patients in second line should get this? Do you think there's a selection that you can how do you decide that now? And do you have any comments for that?
So that's a really great question. When the data from this trial was analyzed, looking for specific subgroups of patients that might benefit more or less than others, we really weren't able to tease out that subset to any great detail. At this point, given that, nivolumab has become my standard second-line agent for almost all patients. That is something that is really made possible by the Compassionate Access Program, so that's not something that is funded or paid for by Cancer Care Ontario. And similarly, at our organization, we essentially administer the medication free of charge. We don't get reimbursed for our nursing time or our IV pulls or any of other our expenses, but to us, given how impressive these results have been, that's something that we've been willing to provide on behalf of our patients until we can get Cancer Care Ontario and the Ministry of Health to fund these medications.
That's a good point. I think that for the average cost for nursing time and chair time at the cancer centers is about $200 in infusion, and some cancer centers are charging that $200. So it's great that your center is absorbing that cost. Is PMH absorbing that cost?
Yes.
Okay. Just checking. Looks like we're almost out of time. So just to finish off, one question. This is a slide showing there's a ton of these new drugs coming out, and part of it's the cost issue. These drugs are about $110,000 to $120,000 a year, and we're also doing a first-line trial with the PD-1 and a second-line trial with another PD-1. So there's about 8 of them coming out at $120,000 a year checkpoint, a price point. Is Deb around here? Where's Deb? Has she disappeared? Any comments on that, Deb? I thought I'd have you comment on the price point.
Keep it close. So Kidney Cancer Canada is putting in a submission to our Canadian Oncology Drug Review into PCODER. It's actually due on Wednesday. So thank you to the patients who helped contribute their input to that. So we play a very strong role in making sure that the authorities know that the patients have something to say about this. These are our tax dollars. And so we have a role in putting a case forward. So we will be putting a positive case to encourage recommendation, but we all acknowledge we need more research. We need to know who is going to respond to these drugs and who is not, because we can't afford to waste taxpayers' money either. So we're walking that line, and essentially we're saying with immuno-oncology, this is maybe the Deb Maskin's position, not the official position, to say, look for clinical trials, because we need to go even further than what this data is telling us right now. We want to push for a cure. And so we're going to find even better than this in upcoming clinical trials. So if you're at a center and your doctor is not talking to you about clinical trials, talk to us and we'll help you navigate and let you know where those expert centers are and where the clinical trials are. This is really, really encouraging stuff. I think we should all be really pleased.
That's great. Great comments. So I think I want to... We have a few questions, and I think this is my conclusion slide for our talk, but before we hear more bad jokes from Stephen, we're going to take some questions. So,
how important is it to pick the right second-line treatment so that if you then have to go into third-line treatment, that you haven't blocked yourself from that third-line treatment? And can we re-challenge the first one if it was very effective the first time?
Excellent questions.
So I can try and help with that. So what you're essentially asking, though, is around navigating our current system. And that is extremely difficult. One of the things that we know from our more fortunate colleagues down south when it comes to access to medications is that many of these medications that are only paid and funded for in first line are still active in third, fourth, fifth, sixth, and seventh line settings. But we don't have access to those medications in those settings in Ontario right now. Right now, when it comes to choosing a drug like nivolumab, we are able to still get access to everolimus afterwards because at this point we essentially hide it from CCO and try and ensure that we're able to get our patients the access that they need. In the same way, when we're talking about IL-2 or interferon, there are patients that I have who are on alternative access schemes, and we work very hard to ensure that they will continue to get access to further medications down the line, either sunitinib or pazopanib in the first line setting, even though technically they'd be in second line. So I think that the choice and the navigation is very important. And again, this is something that you want to make sure that you have a physician who is aware of the options, but also has a team around them to help you navigate how to get access to all of these different options if possible.
Super, that's great. I think that's going to conclude it. Your last point of that question, there are patients that you can re-challenge with sunitinib after being on that first-line therapy, and we had some patients in our experience where they've gone through first, second, and third line, and then you run out of options and you put them back on sunitinib. And the paradigm is that usually you don't go back on the drug that you've progressed on, but we've had patients that have successfully responded after a re-challenge later on. So it's new paradigms we can discuss more in the coffee break. So I'll get you all to move over on that side, and we'll have coffee break. Thank you. Another question? Or
Yeah.
how about we do it on the side? Can we do it on the side there? How's that sound? Thank you.
Thank you very much.